scholars and wonderful friends of mine. And I was just saying about Charlotte, you know, with her retiring, that we're going to miss her amazing presence and her commitment also to caring and finding very unique and creative ways to engage the caring process with our students and also bring it to life. And so I'm very pleased that Charlotte will be sharing her knowledge today about simulation and how the importance of that, especially, you know, since what we've gone through here, you know, in this COVID situation where simulation also becomes increasingly more important with virtual learning. Mm-hmm. And also Dr. Beth King, a wonderful friend of mine who I've known also as long as I've been, you know, at FAU, and we shared that little spot in the social science building there, you know, our offices. And mm-hmm. So I am pleased to present Beth, and we work together in our veteran nursing education program. And she too is an amazing scholar with nursing and caring, as well as with nursing simulation and caring simulation. So welcome both to Charlotte and Beth for the presentation today.
And thank you, Dr. Ray.
Thank you, Dee. Appreciate that.
Oh, you're welcome.
We're going to start off with just a few slides on a PowerPoint to introduce what we want to talk with you today about. And thanks for joining, because I know it's been it's been kind of a long morning, but so we're glad someone showed up, to be honest. We're glad you're here. So we were asked to talk about simulation today, simulations grounded in caring. And so I should probably put this in full screen. Let me see if I can get it in full screen. So we wanted to, everyone's probably pretty familiar with this, but we wanted to start off by looking at the new ANA definition of nursing. And the bolded points that I probably forgot to bold one piece. Oops, let me go back one. Let me escape here. You may just have to look at it this way, you guys, for right now.
I want to add the amazing ANA updated definition of nursing.
Yes.
It is. It just really came out. So I'm not sure everyone has seen it, but they updated the definition of nursing, and the bolded language that I bolded there are the 3 areas of changes in the definition. And so it talks about nursing integrates the art and science of caring, which that was not there before.
No.
It was just the art and science, wasn't it?
Yes, I think so.
Yeah.
I don't think they identified caring.
No. And focuses on the protection. That language was all there. And then they talk about and alleviation of suffering through compassionate presence. Now I probably would take that's another word there, that suffering word that I sometimes don't like. But they didn't have compassionate presence before. And then at the end, recognition of the connection of all humanity. So I really like this definition. It certainly fits with our philosophy here at Christine Eland College of Nursing. Mm-hmm. But it also validates everything that we do. And it validates the need for simulations to be grounded in the science of caring. And so that's what we want to talk with you about today. And there were 2 recent simulations presented at the International Association of Human Caring last June, I guess. Was it June? I think it was June.
Yeah.
21. We presented, Charlotte and myself and the Cape V team presented a simulation. And then there was another simulation presented by Susie Kay. But for our simulation, we grounded it in the work of the Barry Gordon King framework. I think everyone's pretty familiar with that our framework by now, but it really is, it's a way to study nursing. It's based on Boykin and Schoenhofer's work and the College of Nursing's philosophy, using the ways of knowing. And we're going to talk about ways of knowing a little bit more. It goes beyond Carper's 4 ways of knowing into multiple ways of knowing. We use focused questions relating to caring between the nurse and one nursed. We also look at evaluation of outcomes using reflective journaling and aesthetic representation. Now, the definition of simulation here is by the American Journal of Nursing Reports in 2018. I think everyone's pretty sort of familiar with simulation. And here at FAU, we do modified, we do a variety of simulations in our coursework. And we want all of you to share with us shortly about the simulations that you're involved in here at FAU. So we'd like to start off, due to time, we think we're just going to show a peak portion of one of the simulations presented at IAHC. The other video there is by Susie Kay, where she's talking about integrating caring theory in simulation pre-work, simulation, and debriefing. And for ours really uses the Barry Gordon King context framework. Susie's has, where she has, her focus was on using sort of targeted questions in the simulation. And one was grounded in Watson theory, and her post work was a little bit more broad in terms of caring theory. Charlotte, I'm just gonna have you take over because I have to take this call real quick.
Oh, I hope I can. Can I? Whoa, this is gonna be a mistake.
I'm gonna, Janine
Let me see
Webster,
this.
right?
Okay.
She can put a slide together. If you tell her what should go on it and tell her we need
Oh.
it.
Beth, I need you. So
Yeah,
move to
sorry,
the
I
next
was-
slide.
You have a phone number?
So we're just gonna do this, Charlotte. We're gonna open it up. I'm gonna open up the, sorry, let me get out of,
The Vimeo? No.
I'm gonna open up the teaching learning video. Is that okay?
Yeah,
You
sure.
want to say anything else?
No. Oh, yes. Yeah, so we'll give a little introduction. So we're going to present parts of the workshop that we did at the Caring Conference. And we presented a nursing situation and then had students, volunteer students, come and be with us. And they did the explication of the caring within the nursing situation using multiple ways of knowing. In the Barry Gordon King framework, we use multiple ways of knowing, not just, Carper's 4 that you see used pretty consistently, but we've expanded ours to sociopolitical knowing and emancipatory knowing, which really takes into account the what is being published now as the future of nursing, health equity, nursing based on understanding the determinants of health and understanding the context of a person's life. So we're really pleased with the wholeness of the ways of knowing that we use, and suggest that that students learn to take a look at all the ways of knowing to understand the person being cared for.
I forgot one thing, and I need some help with this, you guys. This is a Vimeo. Will they be able to hear it?
I don't know.
As long as you
shared your
choose,
screen,
choose
if you shared your
your
screen with
sound.
audio, you should be able to hear it.
I bet I didn't do
I
that.
would recommend going back, stop and go back in, Beth.
Yeah, and then when I pull it up, help me remember. Don't I do something, share?
Yes.
Beth, do you want to make me a co-host and I can handle the video?
Although we've done this, it says all we have to do is click share sound, right?
Yes,
Right.
Share
Should be
computer
at the bottom
sound.
of the page.
Yep.
You could actually do that while your screen.
I'll text it to you as soon as we hang up. I'll text it to you.
And I
got
just
it. Let me
wanted to
see.
say that the video was a presentation at the 2021 International Association for Human Caring Conference, and it is being used with permission.
Thank you, Shirley.
So let me hit.
You may have
Tell
to
me if
change
you can
which.
hear
There
it.
you go. There you go.
So we're going to skip the intro and we're going to go right to Anne Marie, the nurse
Hello, everyone.
situation.
So this role play is set in the primary care office at the VA in Belle Glade with an initial telehealth visit with primary care nurse for new complaints. The simulation is a role play. The nurse RN is a student volunteer, which is Reed Walk, and the patient is Mike. He's a volunteer actor. New physical complaints. Mike reports that he has been urinating frequently. He reports feeling very thirsty and hungry. Although he is eating more and not exercising as much as before COVID, he seems to be losing weight, which he does not understand. His present height is 5'7" and his weight is 147 pounds in the morning undressed. We've got background information from the medical records from the VA primary care setting. Michael is a patient at the Veterans Administration Hospital Outpatient Care Clinic. Michael is an 88-year-old Navy Korean War veteran. He was honorably discharged in 1954 after sustaining a cold exposure injury during active duty. He settled down in his hometown, East Orange, New Jersey, with his first wife, his high school town to downtown Manhattan, to work as a stockbroker until his retirement in 1983. He and his wife divorced in 1978 after raising 2 sons. Upon retirement, Mike moved to South Florida. He met his second wife, Joanne, in 1986 and remarried in 1987. Family history includes that Mike is married to his second wife, Joanne, who was his healthcare surrogate on record. Mike describes his marital relationship as a happy one. He has 2 sons from a previous marriage and 1 stepson. Mike has an older brother who lives close by. His 2 sons and 5 grandchildren live out of the area. They call regularly. Mike has not seen his brother or children or grandchildren since the start of the COVID virus. Mike has a 20-year history of controlled hypertension and glaucoma for 5 years. He is presently seeking medical attention for the new complaints. His social history includes that he is a BA in economics, worked as a stockbroker until his retirement in 1983. He and his wife live in a middle-class neighborhood in an adult community. He lives on his Social Security as well as retirement investment savings. His wife works part-time on a contractual basis as an educational consultant. Mike reports having one good buddy, Dave, who he now talks to daily on the phone. Mike enjoys going to the gym at least 3 days a week, but has not been able to since the COVID virus outbreak. He has not been exercising for the past 6 months, except for occasional walking around the neighborhood with his wife in the evening. Mike is Jewish, reporting that he has not attended religious services on a routine basis. However, he likes to get together for Jewish holidays with his brother and sister-in-law. And now for the role play.
So I'm going to add that can you hear me if I
Hello,
speak?
my name is Reed, and I'm your primary care nurse today. Is it okay with you to conduct this appointment via telehealth communication?
Yes, it is.
All right, how you doing?
Good. How are you?
Doing well, sir. How would you like me to address you today?
Call me Mike, please. That's what everybody calls me.
All right, how you doing, Michael? Nice to meet you. Are you in a place that we could speak privately?
Yes, I am.
All right, is there anyone you would like to attend in this meeting with you?
My wife is with me, and
Hi.
yes, I want her here.
All right, how you doing, man? All right, Mike. It's nice to speak with both of you, and thank you for your service, sir. Okay, before we start, I need to ask you some questions about COVID-19. Do you have a temperature?
No, I don't.
Okay. Have you been exposed to anyone that has had COVID-19?
No.
All right. Have you traveled outside the U.S. in the last 2 weeks?
No.
We wish.
Yeah, we wish. No.
Okay. Yes. Have you lost any sense of smell or taste?
No, I haven't.
Okay, good. And do you have a cough, sir?
No, I don't.
Okay. Thank you very much. All right, Mike, please tell me what matters most to you today as we speak.
Okay. What matters is that I'm not feeling great. I'm having trouble sleeping all night because I'm getting up 2 or 3 times to urinate.
Okay.
I'm overly hungry, and I'm losing weight.
Okay. I would like to hear more about this. I want you to know that what you share with me will be kept confidential unless you tell me that you plan on hurting yourself or others.
Well, I have no intention of hurting myself
Or me.
or her
Okay.
or others.
Thank you very much. All right. So what you've been telling me, this must be pretty difficult. So I'd like to explore this more. All right.
Okay. Okay.
All right. Can you tell me about what I really want to thank you for making this appointment? I could tell that you're concerned about some of the things that you've expressed to me. There could be many reasons for your symptoms, and I know you've had some lab work done in the last week. So let's review these results and let's see what's going on. All right.
Good. Okay.
Good.
All right. So there's two lab results that stick out to me that I could see, and one is the glucose blood test, and the other one is the hemoglobin A1C. Now, your hemoglobin A1C is a simple blood test that tests your average blood sugar over a 3-month period. Do you understand? Well,
Yes.
what I've explained to you? Okay. So the normal results are about between 3.5 and 6%, and your values were roughly around 8.5%, which is above normal. Now, your blood glucose test measures your glucose in your blood, and glucose is a simple sugar that's one of your body's main sources of energy. Do you understand what I'm explaining to you, sir?
Yes, I do.
Okay. And your glucose was about 130, and the average is usually between 74 and 106. So with these two above normal lab values, we'll have your primary care provider look them over, and they could be an explanation on some of the complaints that you've been having lately. Okay.
Mhm. Good.
All right. So now, next, I would like to review the medications that you're taking presently. I know we have the records, but I'd like to double check what you are currently taking. Is that okay?
Okay. Very
That's
good.
We wrote them down
I
here.
wrote them down. Irbesartan,
Right.
75 milligrams. Atorvastatin, I think that's Lipitor, 5 milligrams. Aspirin, 81 milligram. That's a baby aspirin. Latanoprost for my eyes
Okay.
because I have glaucoma. Senecot S, which I take usually every day, but sometimes I don't.
All right.
Okay, fish oil, 1,200 milligrams. Vitamin E,
Sir.
400 international units. Vitamin D, 125 micrograms. Vitamin B12, 500 micrograms. And I only take that 3 times a week, Monday, Wednesday, and Friday.
Okay. Understood.
Calcium, magnesium, zinc combination tab, once a day.
Okay. Thank you very much, Mike, for sharing that information. This is what we have on our records. Now, tell me if you're experiencing any pain. We usually rate the pain from 0 to 10, and 10 being the worst. Do you understand the scale that I've just provided to you?
Yes, I do.
Okay.
Yeah, I am
Use the happy
experiencing.
face.
Huh?
Use a happy face scale.
Yes, I'm experiencing pain. When I get up in the morning, my joints hurt, my hips hurt,
Okay.
my back hurts.
Don't forget your feet.
And my feet are always cold and tingling. But my
right.
feet are not comfortable anymore.
Isn't that more painful for you, that your
The
feet?
tingling, yeah. And I'd rate that about a 5
5 out of 10.
or
right?
more. Yeah, 5 is probably right.
Okay.
It's not excruciating, it's just extremely uncomfortable.
Okay. Understood.
And that's especially in the morning when I get out of bed. It's like the tingling I've had in my fingertips ever since the Korean War.
Oh. Well, I really appreciate your service. I'm sure going through that war must have been very hard. And once again, thank you for your service. I do have a question though about, have you ever been treated for the cold exposure?
No, I haven't. My doctor monitors it. but I haven't had any
In
treatment.
New Jersey, not.
Yeah, that
or
was in
not
New
lately.
Jersey. That was in New Jersey.
Now that you're in Florida, not so
It's
much.
not as bad in Florida.
Okay. Okay, okay, that makes sense. All right, so now I'd like to do a basic assessment and review the information that we have. First, let's have your wife take your temperature, blood pressure, and count your respirations.
Okay,
Our primary care physician prepared us kind of for a telehealth visit. So I went ahead right before our meeting and took his vitals. So I'm gonna just call them out to you. He had a temperature of 97.8. His
All right,
pulse
excellent.
was 80. His respiration was 16, and his blood pressure was 130/80.
All right, excellent. Thank you very much. Appreciate that, and thank you for being prepared.
Welcome.
Okay, Mike, your vital signs are all normal, and we all have this information. I will call your primary care provider and discuss the findings of the assessment and new symptoms. Then we will get back to you within 24 hours to collaborate and co-create a plan of care with you. Do you understand all the information that I provided?
yes, I do. Thank you.
No problem. And once again, I appreciate your service and your dedication to this country. And if do you have any further questions?
Well, the only questions I have are my weight loss, and
Yes, sir.
I worry that
We have
it might be
in the
cancer. There's
family.
cancer in the family.
Okay. I will definitely let the provider know this information that you provided for me, and he will look over your lab values, and we'll be able to discuss this, and we'll be able to get back to you, and he will be able to evaluate further and discuss your concerns with you. All right. sir?
Good, very good. Thank you.
Thanks so
All right.
much for your time. We appreciate it.
Thank you for your time, and I appreciate it, and hope you guys have a good day.
Thanks.
You too.
You too. Take care.
All right. Thank you very much. Enjoy your day.
Don't move.
All right.
Thank you, Mike and Reed and Joanne as well. That interview went really well. And we'd like now to break the students into groups and to assign them. I think, Marianne, you'll do that. You'll assign them some of the ways of knowing to analyze in their groups.
Yeah, I will do that. I'm in the process.
Yes. Do you think 10 minutes or think 10 minutes is enough?
However long, 10 or 15 minutes, whatever you would like.
Okay.
I think we did 7 to 10 minutes or 10 minutes the last time.
Yeah, 7's too short though. 10, I think.
Right.
Okay. Yeah, let's see where they're at 10. Anyone else have an opinion on the 10 or more?
I would say 10.
Okay. All right, so 10. And then after 10 minutes, we'll bring them back and have them present their findings in the different ways of knowing.
So Dr. Berry, did you want to explain what the different groups are, or?
Oh, sure, yes. So we've divided the groups up by the ways of knowing. So group 1 is going to be taking a look at personal and unknowing. And we have questions that the students have in each of the groups to help them formulate their answers and think about what ways of knowing are important in those two areas. Again, with regard to Mike's situation. And group 2 has the empirical way of knowing, which everyone is very familiar with. It's, you know, the facts, the figures, the lab values, the medications, all that stuff that we study so hard. Group 3 will do the ethical, and there's a lot of ethical issues with telehealth, of course. And so that will be group 3. Group 4 is going to do sociopolitical, which tells us about the person's life, the context of Mike's life.
Charlotte, group 3 is ethical.
Excuse me? Group 3, did I say? Didn't I say group?
Well,
Yes, you said group 3.
Go ahead. Go ahead.
Group 5, then we did group 4. I'm going to go to group 5, which is spiritual and emancipatory. And so understanding the spiritual beliefs of a person is really important for taking care of a person too. It's particularly with support. What kind of supports does the person have? and emancipatory about ways that he feels cared for or not cared for, or maybe has some issues with feeling some injustices towards him. And the last one in group 6 is the aesthetic way of knowing. And this is where all the ways of knowing come together to engage the nurses, ourselves, into thinking about the art and the beauty in the nursing situation, and coming up with a representation of the caring that has been described throughout this nursing situation of caring for Mike. How can it be expressed in a painting or needlework or poem, in some original art form? So the students have 10 minutes. So this will be a challenge, but we don't expect a work of art like the ballerinas on Josefa's wall, of course, but to come up with some idea for that they can express the beauty in this nursing situation with the caring components.
Okay, well, I have everyone. There are 2 people in each group. There are 6 groups, and all of the content that you just described, Charlotte, that's in the handout that everyone has, correct?
Yes.
Okay. All right. So I will be putting you all in groups for 10 minutes. I'll call you back after 10 minutes. And if you have any questions, you can come back to the main group and just ask us a question if you need any help with anything. Okay. Is everybody ready? Does anyone have a question? Okay, then here we go. Yeah,
This is the good part. This,
yeah,
take more time with this then.
Yeah,
That was fun, Dr. Levitt. I like your students.
What group are you in, Joanne?
I was in 4. I had a wonderful time.
Oh, good.
Oh, yes.
Oh, sociopolitical. Nice.
Yes.
All right. I think everybody should be back now. So good job, everyone.
Everyone's back? Almost, or no?
No, everyone is back.
All right, great. So then let's go ahead and start by asking the different groups to present their portion of the ways of knowing and the caring ingredients. And we could begin with group 1, who did personal and unknowing.
And that's Josefa and Kathy.
Mm-hmm.
Hi, so I'll be speaking for us. So for personal knowing, how did we come to know myself in this case scenario would be Reed. As a caring person, we spoke how he was able to understand Mike's past as a veteran and connect with him through that, and just keep an open mind and make sure he expressed understanding towards what he was going through, and how side effects from his past experience with the tingling and the coldness in his feet could affect him as well.
Mm-hmm.
So then for how we found Mike as a caring person, we spoke how Mike was concerned enough for his health to go to a primary care office to make sure that he stays healthy. And he as well showed as a caring person by having his wife there and having her as well express her concerns so that they could both be heard and just really communicate effectively with the RN.
Yeah. Oh, I agree. Would anyone else like to add something to that part about personal knowing? Then we can move on to unknowing. You had unknowing too, Yosef. Who else was in your group? Reed?
And Kathy.
Oh, Kathy. Okay.
Mm-hmm. So for unknowing, how you could set aside preconceived ideas of Mike. There was no bias towards anything noted throughout the simulation. We also noted how Mike was able to keep himself open during his experience with this primary care RN through telehealth, because in the past, VA care has had some struggles with getting prestigious, or not prestigious, but like good care towards their veterans in a timely manner. So he could have preconceived notions about the VA and the care that they provide, but he was open to expressing his needs and everything that he wanted to get accomplished during this first meeting with the RN.
Mm-hmm.
And then for how the essence of caring was expressed, we felt that by Mike having his wife there, there was already an essence of caring because he wanted to keep himself healthy to be able to be with his wife as well. And she expressed her caring essence by kind of adding little comments throughout, and Mike was able to just let her do her thing and roll with it. He wasn't telling her this is my appointment. We did feel that maybe a little something that could have been done a little different is Reed could give some more calming gestures, because we noted that Mike seemed a little bit anxious due to the fact that he has cancer in his family history. So maybe not inching towards a diagnosis, but giving him a little bit more reassuring words before he meets with his provider.
Good idea.
Yeah, I was just thinking one other thing, although in this situation, Reed was a veteran, so he sort of, Reed, you probably had some understanding of veterans and what they might have experienced in the, I think it was the Korean War, am I right?
Yes, ma'am.
Yeah, whereas if you're not a veteran, that might be something, the unknowing that you might need to recognize, that you're not really not aware of what the Korean War was about. I'm always shocked when I talk with students sometimes, like, you know, I might introduce, yeah, I sometimes say, well, remember when John F. Kennedy was shot? Well, my students don't even remember John F. Kennedy. So, you know, those are the unknowing aspects of the care that we sometimes need to reflect on too. But Reed being a veteran does make a difference in caring for veterans. Yeah. The unknowing is always an interesting way of knowing, isn't it? I actually love it. It was presented by Munhall.
It's like apophatic theology.
What was that, Richard?
I said it's like apophatic theology, and well,
Empathetic, apathetic.
apophatic, negative theology.
Oh, okay.
Where there's Donald Rumsfeld, the known knowns and the unknown knowns.
Oh.
What you don't know, you don't. Here's what you know you don't know, and here's what you don't know you don't know.
Yes.
Yeah, yeah.
And we sometimes describe it to students as being open to know the other, you know, put aside everything, put aside, as Josefa said, preconceived ideas, and just be open to understand who the other person is.
And I think Heather was going to say something. Were you, Heather? No? Okay.
And can I just say something? I think it's important for us to realize that if we didn't know about the Korean War and we didn't know what cold exposure was, it's okay to ask the other to explain it a little bit. So it's learning back and forth.
That always surprises me because I always think Korea's hot. I've never been there, but I think it's hot like here. So when someone has cold exposure, I'm reminded it snowed and people are very cold. I guess they still are, of course. But
Winter Olympics.
People are very cold.
Yeah, Dr. Harvey, like you were saying, the back and forth and the humility is kind of what you're pointing out, I think, in admitting that you don't know something and trying to learn from the patient, you know, opening that dialogue with them is super important. It tells them that you're centering your care on them and their wants and trying to understand them where they are, the patient that is, instead of sitting there wagging the finger that healthcare providers sometimes do inadvertently, hopefully inadvertently at least.
Right.
Can anyone think that alternating rhythms might be a caring ingredient in this particular topic, the unknowing?
Alternating rhythms. That takes me into the notion of aesthetics, but there's overlap in all of these categories.
Yes, there is.
Categories do.
And Richard, that's part of us presenting the different ways of knowing, because students, when we all go in with this huge amount of knowledge and really don't know where it comes from. So we try to, it's like unraveling a weaving just to see the threads that are are incorporated into it, so you can understand so much of what we.
I'm mostly familiar with Barbara Carper's writings on this, and you've added some others other than her four.
Mm-hmm.
I had it looked to me like the primary purpose of this interview was empirical, and he was reviewing physical signs and so forth, and the right now. In such a situation, it's not necessarily desirable to go into that other area where there might be a lot of emotion and you have a lot of unknowing yourself. He came on with a lot of assumptions and put his assumptions out there, which immediately put that in the box as instead of decide. Even my background is 20 years working with active duty military and veterans with PTSD and addiction. That's been 20 years doing that. Consult liaison for addictions, and a polite thank you for your service has a tendency to put that in a box and shut it down. There's a lot of assumptions on a person's part. That's a social nicety thing. How are you today? Fine. Just automatic responses. And I know, I don't know how he knew this, but he told him he knew how hard the war was for him. I'm curious if that was part of his knowing. I guess it's in the history.
So we're going to talk about that, Richard, when we get to ethics.
Okay.
So we like to do all of our ways of knowing to help. Everyone likes empirical, and we're all pretty good at empirical. But sometimes the other ways of knowing, we're able to see the whole person. So
it's
that's
probably also the biggest lie of them all.
What was that?
It's probably also the biggest lie or biggest myth of all of them.
Oh, empirical.
Well, when I went to school, that's all we learned. So I just love the ways of knowing, because it just expands our understanding of the knowledge we bring to nursing. Are we ready to move on to the next way?
Yeah.
Which is empirical. As a matter of fact.
Yes, it is. So I did this with Dr. Rampala helping me a little bit there. I appreciate the guidance. So what I'd like to look at with the empirical is the factual knowledge, like we talked about, what we know scientifically, the lab results, but also the words that our patient used to describe what was going on and how he felt about things, along with his wife. So physically, we know that there's pain. That's what he expressed. The pain I'm thinking could possibly be arthritis pain, could possibly be the beginning signs of diabetic neuropathy. The reason why I'm kind of considering the arthritis pain also is because we do know that he was a veteran, and being a veteran myself, I know that we can be kind of hard on our bodies. If he was in an airborne division or anything like that, yeah, he's going to have a lot of pain. It's just really hard on the joints. So I don't want to necessarily pigeonhole just the diabetic aspect of this. I also want to look at some other possibilities as well.
Spinal stenosis.
Yep, there could be a lot of things going on. Absolutely.
Just age.
Well, pain is not necessarily something that is normal to aging. We tend to think that it is, but I don't want to discredit his pain ever by any means. Pain is definitely what the patient perceives it to be. So then his vital signs all were great. Everything was within the normal limits. He does take some medications that I think help him stay within those normal limits. So that's good. He seems to be staying on top of some things, just looking at his medications. He did express anxiety, and he seems like he has done some research on it, because the troubling sign to him was his weight loss. and he has a family history of cancer. And go on Dr. Google and you ask, what are some common symptoms of cancer, and weight loss is going to be up there. So then looking at his lab reports, we highlighted his glucose was elevated. I don't know if it was a fasting glucose or whatnot, but it was definitely elevated. His A1C levels were elevated. Both of those numbers are telling us that he's had some high glucose and that it's persistent over the past 2 to 3 months.
Why do we look at the A1C?
So the A1C is going to tell us what basically what his glucose control has been over the past 2 to 3 months, because these glucose molecules will stick on to the red blood cells, and the normal lifespan for a red blood cell is about 120 days. So as those blood cells die, new ones are being regenerated. So we're only getting that 3-month period snippet of time that we're seeing what his glucose levels have been at.
Yeah.
So, and the higher that A1C number percentage, the more out of control his glucose levels have been. So that could be from diabetes, it could be from medications, it could be from infections. We definitely need to explore it further, have a doctor do some more workups, and kind of expand on that.
I love the fact that he even knew he was familiar with A1C. 5 years ago, I'm not sure patients really, we didn't.
Oh,
talk about it as much.
absolutely.
Yeah.
Yeah, it's
And now
all
it's on
over.
TV.
Oh, big time. Yes. Yeah. Yeah. I mean, well, diabetes is becoming quite the epidemic. And I think that it's really on all of our minds as providers and just people living in the world that we live in today.
Did he have any other abnormals on his lab values?
I'm sorry?
Did he have any other abnormals that you might be concerned about?
He had some hyperlipidemia, some elevated lipids that were slightly concerning. But in his med list, he did have atorvastatin, a statin. So when he goes to the doctor again, they might want to take a look at those levels and maybe adjust his medication.
Yeah.
Up it, or I mean, just kind of take a look at the whole picture.
How was his kidney function?
Honestly, I don't remember. I think that it was good. Billy was good. Glucose, ketones were negative.
So why as an
Protein
RN should you look up those? I'm looking at all of you. Why as an RN should we double check those lab values and maybe, point out to the provider?
Oh yeah. Well, because diabetes has a tendency to tear up the kidneys quite a bit.
Yeah.
So yes, the creatinine was slightly elevated.
That was.
And I'm looking for the and the BUN
sometimes
as
we have a
well.
tendency not to maybe look at the lab values as closely as we could or should.
Yeah, that's a good point. We do tend to hyper focus.
Yeah. So thank you. Any other empiricals on him? Any other?
No, we talked about some caring concepts that we would use to guide our care in our empirical knowing. Competency, of course, being top of the list with this one, because you have to have the necessary knowledge on pharmacology, pathophysiology, and the healthcare system to really get at that. Comportment is going to be huge, because you want to be sure that you're expressing that you're listening, but you also want to present your knowledge to the patient in a professional way, in a non-threatening way, in a way that is giving them the knowledge, giving them the power to make the decisions that they need to know going forward. And to me, commitment is in everything that we do. We have to be committed to lifelong learning. We have to be committed to our patients. We've got to be committed to our profession. But those were the 3 caring concepts that I felt really guided me in my empirical knowing of our patient.
Yeah. Thank you, Heather. Would anyone like to add anything to that?
Well, I was just going to bring up one other aspect that to make sure that we always look at their medications, because he was on the glaucoma medication, remember? What was it? Latanoprost. So you always have to worry about any interactions with that medication for raising blood pressure. So
Yes, and Dr. Rampala brought that up when we were
okay,
speaking.
yeah.
I'm not very versed in the glaucoma meds, but she brought me back to it.
Yeah. So and you'd want to talk to the patient about it, to make sure that they're
Absolutely.
aware of it too.
The blood pressure, we exceeded a little bit the current recommendations.
Just a tinge, didn't it?
It did,
Some
but
would call that high.
Yeah, it was.
He's 88 years old, so the recommendations are much higher at that age group.
Oh,
Yeah.
right.
He doesn't look 88, but he is, or so we think. So he
He's
says.
aged very well.
And
Yeah.
he's also very anxious. So that
Yes.
could bring
Yeah,
up
you're right
blood
about that.
pressure.
Yeah. Good point.
There's the glaucoma brought to mind too. Was there ever any question of, it's common knowledge, I think, that marijuana is often used for glaucoma. Had that information come to him? Has he, and you could, go on. I don't know how much he drinks or any other recreational substances he might be using.
Good question. Good thought. Yeah.
Yeah. Thank you.
I like that Heather brought up the possibility of interprofessional collaboration and her bringing up about these pains that they could be from some other areas. And I think Heather suggested, I don't think she said specifically, but I like where her mind is going. She's thinking, who else can I bring in to the team, perhaps, in the next steps.
Yeah. And that's the beauty of following, using the community nursing practice model as a theoretical approach. It's the nurse is expert in nursing, the patient's expert in their own care, but we have all these other experts to bring into the mix to provide the best care.
I had one comment about talking with patients about the empirical values, particularly lab values and that sort of thing, is when we use language like describing what an A1C represents, when we use language like out of control, particularly for a veteran population, that might sound pejorative, that your A1C is out of control, or it represents blood sugar being out of control, as opposed to saying it represents your blood sugar being elevated over a period of time.
Yeah. Did we say out of control? I don't think we did. Are you just saying that in case we would say it?
Well, Heather used that description, but I think it's a common description.
Oh.
So yeah.
Yes.
Just to be aware when you're with a particular person or population in general, what some of that languaging might be.
Sometimes older people, they seize on a word or an emotion, because I see that in my own husband. And, so I think Dr. Gordon is right that language is so important. It's part of the caring.
Absolutely.
I don't want to spend all the time on empirical, but Heather also brought up the comportment issue as a caring component. And I was at a presentation a couple of years ago about taking care of people who have been Holocaust survivors. And he's Jewish, and I don't know whether he was in the Holocaust at all, but not to wear striped clothing in particular. And there's some sort of a way to be with people where you never say certain words and you don't wear certain clothes because it's too suggestive of their life. It's a really interesting. There are people that have studied, the social workers, that address that in particular.
Yeah, and one of those is tattoos, covering up any kind of tattoos or piercings or any of that kind of thing. It's really part of the comportment, but it's also part of the professionalism and the respect that comes out of the interprofessional education and collaborative practice. So thank you for mentioning that.
Yeah. Thank you. Are we all right to move on to ethical? Group 3? Okay. Who is in group 3?
All right, that was,
Reed and Beth.
Okay.
all right, so how does the ANA Code of Ethics Guide care? So for this situation, I picked provision 1 and 3 for the specific reasons, as provision 1 says, all professional relationships practices with compassion, respect for the inherent dignity, worth, and uniqueness of every individual, unrestricted by considerations of the social, economic status, personal attributes. Because of the background that was provided, you know, it was the whole scope. You learned about his family history, economic, pretty much his whole entire life. And then on provision 3, the nurse promotes, advocates for, and strives to protect the health, safety, and rights of the patient. Into second question, am I non-judgmental? I believe so. And the reason being, as a veteran myself, and I heard the gentleman speak earlier, when I deal with veterans, especially me,
Excuse me a second. I don't know if you guys can hear me. But we're going to skip over the ethical part and just go to sociopolitical. We're going to skip over parts of this way of the students presented, the multiple ways of knowing, just to show you some more important context. We want to go to sociopolitical because it is so important, especially now, to know how the social determinants of health influence. I also want to say, I thought you reacted really well when he said he was afraid of cancer, because it's very easy to blurt out, oh, don't worry about that.
Right.
I don't think you have it. It's just, it can roll off. It could roll off my tongue. I have to like bite my tongue not to say something like that. So you just left it open. Okay, we'll take another look at it. You know, you acknowledged his fear. And, you know, examining it is the right.
As far as his healthcare goes, because she is his healthcare surrogate, and she often speaks up for him when it comes to conducting.
So Dahai is speaking about sociopolitical knowing.
On any key information to inform the healthcare provider of during the visit. So she seems very supportive. As far as work goes, the patient is retired, so he is in retirement. So taking into consideration from the social history, he lived in East Orange, New Jersey, and he commuted for work to the big city of Manhattan. So going from living somewhere that is so fast-paced and retiring in South Florida, I'm sure he has a culture shock dealing with the different cultures from coming from somewhere that is so fast-paced to South Florida that is very relaxed. And then as far as his responsibilities, he seems to be very interested in his medication regimen and paying attention to what the medications may do to his body and the side effects. He mentioned the twitching from the Korean War and his history with cold exposure. For cultural values, I would say that a call to nursing for me was definitely when he mentioned that he wasn't able to, from the social history, be able to attend routine the service that he would attend for his religion. And I'm sure that is very difficult on him, because a lot of the times older adults, they get very used to routine and they like routine. So when COVID happened, it can be very difficult to have to shift from that routine and getting used to social distancing and everything being online. I would also touch on in terms of having easy access to healthcare facilities and being able to obtain medications and safe housing and leisure activities. In the social history, it mentioned that he retired in South Florida, but it didn't really say what part, like he could be in Century Village or he could be in somewhere that is more fast paced. So he's easily connected to different healthcare facilities. So I wasn't really sure what his situation was as far as access. And in terms of the essence of Caring Express, I would say for Roach's 6 C's, definitely compassion. When we speak about the nursing situation we saw here tonight, I would say Reed's overall gratitude for Mike's service was also very evident, and him asking just a simple question of how would you like to be addressed? is very important as it shows the respect between the nurse and the patient. And that is really important, to just go the extra mile to make sure that they're comfortable. And being able to say, are you comfortable with conducting the visit via telehealth communication? I thought that was also great. And are you comfortable with your wife being here while we conduct this visit is important as well, as we know that it is important for the patient to feel comfortable during the visit and make sure we have their consent to carry out the visit. So that's all I would have to say in terms of socio-political knowing and what I gathered from what I heard tonight.
Thank you, Dahai. So Would now anyone we're else going like to to add move something to in the one other socio-political section realm? about aesthetic knowing,
He did
which
a great
is very
job.
often difficult to teach students about, but
I think he also
had
brought
very
up
little
about
time.
the
So we're going to go to
the
last way of knowing is aesthetic.
Piercings, all
think
of
it's-
that stuff, because it might make him uncomfortable if
Oh.
someone had any of that stuff. So you want
It's
to
before there, Beth, sorry.
And
Richard was in.
All a way of a big sign of respect from one veteran to another, and I felt that that was a really good way to say it. Even though they're from two separate generations, it's just a huge sign of respect, and I felt like that was very important. Then how can I express the beauty of the caring between Mike and the nurse in an original art form? Me and Anne chose dance because we felt that this was the questioning, and this whole type of going back and forth was kind of a way of a dance, because there was, so Nurse Reed would do like one move, give one question, and Mike would give an answer in a different type of dance move. And some of the moves may not correlate, so Nurse Reed would probably have to do another dance to kind of catch up with Mike, or at least be on the same rhythm and flow as Mike. And in the end, they were both asynchronous dancers, because they were both on the same flow and the same rhythm. So
Oh, Rakeem, what a beautiful depiction of that.
Yes.
I love it. Thank you. And thank you, Anne, that you worked together. That's a great description.
Please tell me we're going to see you dance, you and Anne.
Maybe not this time, maybe some other time.
Okay.
I love the, sometimes we're synchronous and sometimes we're not in synchronous.
Yeah.
Great.
It's like a matter of catching up, and then once you're there, it's like a cycle, like everything.
Beautiful.
But you keep on dancing.
Your hands were so rhythmic too. Your hands, your motions while you were speaking.
Oh yeah, so I was just trying to visualize it.
I was, when you were talking about thank you for your service, I could just see it up on the screen, you know. I was thinking you might go that way, but I love that dance idea.
So,
Thank you.
Dr. King, we're going to stop the Vimeo now and go.
And we did not set you
other
up for that. That
participants.
was fantastic.
Oh, good. Okay. So we wanted to give you an idea of this unrehearsed nursing situation and working with the students. Now, the students did have, in most simulations, we do give students some prep work, articles to read, PowerPoints to watch, so they're familiar with what the content of the nursing situation is. And we tell them to review the caring concepts of Rocha-Mayeroff, and then we, engage them in this. So this was totally unrehearsed, as you could probably tell. But we want to show you how the students were critically thinking through their responses. And I think that is what we need to be teaching our students, how to critically think through, take the information that they can secure through the chart and through talking to the person, and critically think about what's going on here and how can I be helpful to this person in this particular situation. And of course, in our framework, we use a broad spectrum of ways of knowing that go beyond the four that a lot of people use Carper's 4, just to really get to understand the person. And in this day and age, emancipatory is about justice issues and inequality, and sociopolitical, of course, is about the context of the person's life. And we also do spiritual as well, and to know what the person's beliefs are, what support systems they have. so that the students can really, or nurses, when they're nurses, get an idea of what this person's life is really like. So I think, Dr. King, you want to say anything too? Oh, you're muted.
You couldn't figure out how to do some of this. I love also by re-looking at this nursing situation, we can sort of evaluate our own teaching methods and our responses to students and think about ways that we could improve ourselves. So I love the value of videotaping because the students can do the same thing. Like Reed, I'm sure in re-watching his presentation, I think, well, I could have done something a little bit differently. So I encourage all simulations to be videotaped because you get another dimension to look at.
But I think you can see with using multiple ways of knowing that cover all the ways of knowing that we want the students to be familiar with and caring for persons.
Yeah.
Well beyond the empiric.
So sometimes what I hear from faculty when we do simulations, they focus a lot on empirical because we know that's something that we have to teach. That's like probably 90% of what we teach to students when you walk into a classroom. But all those other ways of knowing are equally as important to see the whole person and to develop our care for that person. So, you know, while I think we just need to learn ways of giving equal attention to all ways of knowing to be able to give the care that we really want to give to our patients. So we were interested in, let's see, so Savina is, I was going to just read, Savina looks like she's typing something here. So
you want me to just say it?
I would, thank you.
Yeah. Just within this past week, I have encountered a nursing scholar in Brazil called Fernando Rigel, and he's developing a theory which he calls a middle range theory, which he calls holistic critical thinking in nursing. And it's particularly applied to teaching, working with a nursing diagnosis. And so you and Charlotte both mentioned critical thinking, so I just wanted to share that resource. And, you know, adding holistic to the idea of critical thinking really, I think, changes it in a very effective way for us. Keeps us from focusing just on the empirical and calls us to pay attention to the whole person and all ways of knowing. So,
Savina, did you type his name in the chat?
I did. It's
Good.
Fernando Rigel, but I typed it in there. He's got 5 or 6 publications.
Good.
He's
So
going to be
we were
presenting, or he did a what do you call it, abstract submission to the upcoming Virtual Nursing Theories Week. So hopefully his work will become, you know, more broadly known.
I think Andrew had a question.
Well, I was just going to make a statement based on whoever just talked about videotaping and the value of that. As we're digging, Dr. Longo and I are digging deep into the webinars and all for the competency-based education. One of the things that keeps coming out is it's not always just faculty evaluation of these competencies, that there is both self-evaluation is considered a part of competency-based education, as well as peer evaluation.
Yeah.
And so, you know, it made me think of that when someone mentioned videotaping, because I think with these type of simulations and encounters, actually videoing them and allowing the student to watch themselves allows that opportunity for that self-evaluation, as well as, you know, whether it's real-time peer evaluation or watching the video again for evaluation, it's another aspect of that that can contribute to the competency-based assessment as well.
Yeah, and I think at the end, we actually do a little peer evaluation about ways that the student may have been able to, some other ways of saying things, I guess is how I would say it. So we did do that at the end. But we were interested in how everyone is integrating caring science into your own simulations. I see Lisa came on.
Yeah.
Yeah, hi. First, just it's a
Lisa,
FERPA.
Lisa, we're having trouble hearing you. Maybe you could turn off your video so we could
Okay.
hear you better.
Okay, sorry.
Yeah.
So what is I think it's the FERPA about showing videos of students outside the class? That was one
They
question.
all signed, yeah, they all signed a release.
Oh, okay, great.
Yeah,
Okay.
everyone on that video signed a release.
Okay, great. And
they were all volunteers too. We didn't select them.
Awesome. Yeah, but they still have to sign the release, I know.
Yeah.
But the second thing is in response to your question, your book has just been, I think you all know it. I don't know if other people knows it. And I think Katie still does it in the NUR 3115. We have the students, they get randomly assigned one of the 10 chapters in your book that presents the nursing situation, and they in groups have to then act it out. And then we talk about it, applying ways of knowing, and also other caring science principles. And, it's short, it's impromptu, it's not anything they have to do ahead of time, but it's really been a great thing for that class.
Nice.
Thank you, Lisa.
Yeah. Marianne, you look like you were going to say something, I think.
Well, two things really. To answer your question, I know I teach acute and complex med surg, and we are pretty heavy empirical in that. But whenever we do a nursing situation, we always bring in the other ways of knowing what's most important to the patient and to the patient's family. So we don't forget that, even though we do have very heavy, amount of empirical knowledge. The second thing that I was going to say was this particular group of students that volunteered for this workshop was this was an accelerated group that probably had the least amount of clinical of any other group lately. And they were a great group as usual, but I think to see that you can have a meaningful telehealth evaluation of a patient was very significant for them, that even though they didn't have that one-on-one with patients, they'll have a connection with their patient.
Mm-hmm.
So we wondered about how's everyone used, we know ATI was really integrated heavily in the undergrad curriculum especially during pandemic. So the ATI videos, how did you then incorporate caring science in your work with the ATI videos? I know there's some, so Raquel, maybe anybody do the ATI simulations?
I haven't, okay.
Go ahead, Raquel.
Oh, I don't specifically speak to any theory, but we do cover many of the C's, competency in our discussion of what the skills that we're doing and so on, how they communicate with the patients and so on. But like I said, I don't specifically address a particular theory.
Yeah. So Raquel, is that with students that are at the beginning of nursing?
Yes, they're in NUR 3119C.
Yeah.
Foundation.
So I always thought that, at the beginning of nursing of the student's career, we do focus heavily on Roach and Mayeroff. But then by the time they're moving into that senior year, we should be moving, we should do those, but moving beyond that into, so what caring theorist is going to, what guides their practice? Because we say we're a theory-driven practice. So it's really help the students start thinking about that as they are going to move into their careers.
Well, on orientation, I talk about the 6 C's that they'll be evaluated on, that's how they're going to be evaluated. And And I stress especially the communication, because I like the class to be light, but I tell them not to practice things saying things they wouldn't say to their patient, to their colleagues, or to the mannequin, because the mannequin is your patient.
Yeah.
So I stress that caring begins there. And so even though they're gonna be light and make things fun to learn, they have to be thoughtful in their responses to the
Yes.
what
do you guys think? How can we help students begin to think about theory-driven practice? You know, we would probably prefer caring theory-driven practice. Any thoughts on that?
I have one, but Shirley has her hand up.
Oh, okay.
Yeah.
I'm not good at those hands.
Well, that's okay. My
Sometimes
hand
it's
is up.
up there for, no
Yeah.
reason.
I had a comment earlier, just in relationship to the self-evaluation and the idea of having students record themselves, and whether that's something that's shared with faculty or not. If they recorded themselves at the beginning of the semester and then at the end of the semester and compared how their confidence and comfort and confidence had grown in the use of this approach, would be helpful.
Great idea too. Yeah.
One of the things I really like about Reed's presentation, even though, we could critique it, made Mike feel so comfortable. They were even laughing about, we wish we had traveled. And he really created, I think, a trusting relationship there and comfort with the patient he was with. I thought it was very interesting. Again,
Yeah, I agree with that. Going back to your question about how can you get the students to think about, theory guided practice. So again, in 3115, students have to write a philosophy of nursing, and I had included in there that they had to pick what theory they thought might guide their practice in the future. Now they're brand new to the program, so they basically look for a theorist that they kind of liked and then pick that. But it would be great to carry that through, a course every semester, say, okay, we know that you picked a theory, in your foundation class, where are you now? Are you still feeling like that's the theory that's going to guide your practice? And just talk about it in every semester. And then in the postgraduate programs, the same kind of thing.
Yeah.
Them write up what theory is going to guide their practice.
Well, another possibility might be in our book that, we have a chapter that addresses various theoretical frameworks. And one of the things that is in that chapter is how the focus of nursing changes. So you could have students take one of the nursing situations from the book or from their own practice and assign each group to look at that nursing situation from a different theoretical perspective. And what are the questions that would be generated? How might they approach that nursing situation from a particular theoretical framework? And then people could then see how theory might be very different, based on the nursing situation.
Shirley, and I could see them doing that, as they move along in their trajectory in terms, junior, senior year. It'd be a great way for us to sort of track how they're progressing. Now, so I think you were getting ready to say something.
No, I was just going to say how beneficial this was. This semester, I'm not teaching any simulation. I have the didactic mental health, but next semester I do. And last year was all about just becoming familiar with the sims before you can really beef them up and add all these elements to it. But I'm already seeing how to envision, because I'll teach the didactic and sims, how to really differentiate, but show the connections between didactic learning and bringing in some of these ways of knowing and breaking them into groups and having them discuss and coming back together to highlight all of those based on a virtual sim or something like that.
So we even did it in Marianne's didactic course. We would come in and we did one of the sims in the didactic portion. So the simulation can be done a variety of ways. You know, you can do it clinically, you can do it didactically. We've even done it in post-conference groups.
Mhm.
So, yeah.
And depending on the time, you can tailor it to the time allowed. We had a lot of time in the workshop, so we could really engage the students and help them, I guess, share more, bring up the knowledge they had embedded someplace.
So I see, I see you, Andrew, once, but I want to follow up with him. Did the ATI themes bring in any, did they talk about caring at all in there? Did they use the language of caring?
Probably, these aren't the ATI sims. This is the one with the course point.
Oh,
virtual
sorry,
sims.
yeah, sorry. Okay,
Yeah, I wouldn't say they bring in the language of caring. It's very much like you're just trying to get the empirical ways of knowing.
Yeah.
Really, that's what's
Yeah.
highlighted. And therapeutic communication, because it is psych. There's a lot of that part in it too. But I mean, you can tailor that to be a way of caring, the way that you talk and discuss these concepts with patients. You don't want to use stigmatizing language.
No,
and you see that in the sim. You know, they
But
they
we
try
need to
break away
teach
from
them, we need to teach them how to transfer that knowledge into our care, into one of the ways of knowing our caring language.
Mhm.
Especially if they're not, if that's not how they're geared.
I
And
only use the.
Sorry, Raquel.
I only used the VSIM that last year.
Yes.
Fall when we just started.
Yes.
With COVID, I only used the VSIM that semester with the students, but I gave them questions and to prompt them about the compassion and stuff like that in the discussion, because they did have a reflection portion of the VSIM.
One thing Charlotte and I had wondered, and give us your feedback, wondered whether if we could, what do you guys think about developing some language, caring language, like to help you maybe write a discussion board or something related to the simulation, that it would get to start thinking, about caring science. Would that be beneficial?
Yes, I think that would be great.
You could tailor it to your courses, to whatever.
That would be, that's just what I was getting ready to write about. I was just getting ready to write a thing after hearing the previous sentences. Every course, when you run in, when you're trying to teach, when you're trying to help the students learn something, think about how to frame that as an expression of caring, and use that language and write that stuff down. You know, like I've forgotten the word that Narciso said, but what kind of language do we not want people using? Derogatory language. Okay.
Stigmatizing, I think he said.
Stigmatizing. Translate that into a caring language. How is using non-stigmatizing language an expression of caring? You guys, if you're already doing this in your courses, write all these actions down, and then put them all together, and you could put them into a big guidebook that would help people reframe their thinking to have everything framed as caring.
And sometimes it's just, once you have sort of some of them written down, you can reuse the similar language in the next time you teach. You just have to tailor it to whatever you're talking about.
And there are some suggestions right now in the case studies and caring book. We have a lot of questions in there too that could help you right now.
I think Andrea was going to say something.
Yeah, Andrea.
That's fine. Yeah. So everything you guys hear coming out of our mouths for the next few years are going to be about the domains and that type of thing. So I just encourage you, if you are creating anything new, I put a article.
I saw that, yeah.
And this actually is a really good article that talks about, you guys were talking about VSIM and a matter of mapping VSIM to end of course or end of program outcomes. And so I encourage, as you're envisioning this, if you do map that, anytime you're creating something new, it gives us that documentation that we need, that we're integrating this throughout every, into the curriculum. And it just gives you a map of making sure that you are attending to all those elements, that you're making sure that you've got caring science in there, that you're doing all that. So I just wanted to put that out there as you're creating new simulations, to really think about how they are meeting the domains, and that patient-centered care aspect of that speaks very much to our caring language.
May I respond to that, Beth? Say something about
Yeah, absolutely.
As I see it, the first thing that needs to be done is to translate all that stuff into the framework of the curriculum. Then teach it from the framework of the curriculum. Don't try to change the curriculum to the language of this external set of values and practices, but translate those external frameworks and guidelines into an appropriate language for the curriculum. Then it's easy to track. Does that make sense? I mean, is that work already being done to formalize a translation of all these things, whatever it is that's being imposed from externally? Is that work already being done, that translating work?
I'd say yes. We just worked on the DMP syllabi, incorporating, now we never use the word, no one used the word translating. It's like incorporating the language of the domains and of the competencies into caring language, and going back and making sure that what the subjective was, grounded in one of Roach's C's, was carried through in the new subjectives.
Okay, something is going to be translated.
Yeah.
Either people, and I already hear this, either people are going to translate the caring framework into these, whatever these things are you're talking about, and within 2 years, that will be the framework. Or you're going to translate that stuff into the caring framework, make it your own. Don't make you, don't.
So I hear what you're saying.
Directions you can go. You can either become these external ideas, or you can change those external ideas to fit what is needed within this curriculum. And that has to be done, I think, deliberately and formally. That's just my opinion.
Charlotte can speak to this, but I feel like what we did is we had our caring curriculum as the skeleton, as the framework, and we used those, how do those fit within it? So I feel like we started with our curriculum, and then, like we knew technology, that we had to do some additional stuff related to technology, but we also tried to keep that grounded in caring science.
Well, look, there's no problem keeping that grounded in caring science. Most of you know Rosanna Loxon and his middle range theory. That's already there, and it's already about caring. So does it need to be embellished a little bit with these new ideas, or do we just need to recognize that what seems like a new idea, we're already doing, and we're already working with that? I don't know.
One aspect of that, and I don't know, any of us that are doing telehealth or in any of our courses, we could be making sure that Loxon is at the center of that language at that simulation. Probably most of us do, but it helps students understand that there is a caring theorist already out there that's integrated technology into caring science and technology together. So we should be looking at that when we're focusing on different aspects.
I have a question.
That's an interesting
that
question.
should be the lens through which it's seen.
Yeah. We'll have to think about whether we're really doing that. I don't know. What do you guys think?
I've been pretty pleased with what we did with the DMP program.
Mhm.
And I don't think we have to infuse Loxton's theory into telehealth, but I think we can infuse any caring theorist theory to guide what we're doing.
You could, but to get students to even, if they don't, they may not even know about Loxton. Especially at the undergrad level. They may, they may have studied him in 3115, and then, that's one module in 3115.
So
Yeah.
don't they use technologies in every clinical course?
Yes,
Then why
technologies.
wouldn't that be a core frame for every
It absolutely
clinical
could be.
course?
Yeah, but we just need to keep thinking that way, Sabina, I think sometimes we sort of get focused on, I don't know, trying to get through the course itself.
I know,
Yes.
it's easy for me to sit back here and say, because I don't have any
No, it's a
courses
great-
to teach.
No, that's why we like to have these discussions, because it'll help us to bring it forward when we, next time we're teaching the courses. But you're right, technologies in every one of our courses.
Well, supposing we're going to be doing content analysis between the courses. And I
Mapping.
was that the caring course was taught, and then that was set aside, and then they went into, other topics and other courses. And I don't think it's really integrated. But I think when we do this content mapping, that we will be able to integrate it and see that it really hasn't been. I mean, that's what I think.
I got 2 minutes and I'll share a story. So psych mental health, advanced practice. We teach theory for 2 straight semesters. So the last semester, they're doing a competency simulation with an outside person and coming up with a treatment plan. Almost every student referred the patient out for therapy. Yeah, they didn't do the therapy themselves. So, I'm like going, oh my God, something we're not translating, we're not teaching, something's happening that they're not understanding that they can do this themselves. But they're not seeing it in practice. That's part of the dilemma. So I think we just need to help each other. Even writing discussion boards, if you can get a great discussion board that really helps the student, talk about caring science and integration or whatever the question is, use sort of that same framework for the next discussion board. Maybe everyone's doing that. I don't know. Sometimes I forget,
I don't know if I can talk. Good
Hi,
evening,
Elizabeth.
everybody. Hello. Good afternoon, everybody. I'm just thinking as we're discussing, like we can bring situations like in the lab when we are teaching students how to pass maths. Sorry with my voice. When we are teaching students how to pass med. So, and definitely when they're in the clinical setting, they are going to document in the same room when they are passing med. So how do you communicate with your patients as you are documenting using the technology in the environment? Do you like back your patient and just be like, take your meds, I need to document. So I think bringing all of that in as you are teaching, so bringing the theories in, but not like majoring on the theories, but bringing what we have learned from the theories, that you are able to communicate and care for your patients as you are passing meds, as you are using technology, as the therapy people are coming in to care for you. You can be all involving and collaborating together while you're caring for your patients. So that's what I think.
Thank you. Thank you.
Thank you, Elizabeth.
Okay.
So it's on my phone, it's 2:30.
Yeah.
And I know there are other meetings this afternoon. Is there anything that anyone would like to say that is just pressing on you right now to add?
No.
There is. You could write it in the chat and we could say the chat, but thank you all so much for being here and for the stimulating conversation at the end as well.
Yeah, it's fun, isn't it? And if we help each other, it's just so much easier when when I'm looking at I don't know, the last time Charlotte and I had to come up with a discussion board, and I said, and I got to figure out how to bring caring into this, what I wanted the discussion board to be about. So we brainstormed and, I kept that framework for the next 3 questions. Really helpful.
And there's multiple ways to do this from different theoretical perspectives as well. There's no absolutely do it this way.
No.
So thank you for attending today. And thank you for helping us learn. And happy Thanksgiving to everyone.
You all too.
Thank you so much.
I'll see you in the next meeting, Beth.
Bye.
Bye. I'm going to copy this chat, Charlotte.